Hello dear students. Today we are going to discuss about pathophysiology of the digestive system and pathophysiology of liver. The main task is to explain mechanisms of development of most common GIT disorders, such as an acute gastritis, gastroesophageal reflux disease, acute pancreatitis, peptic ulcer, duodenal ulcer, mechanisms of development of pancreatic shock. Then we move to the pathology of liver, and we'll discuss about the mechanism of development of jaundice, its laboratory characteristics, different diagnosis and prognosis. We are going to discuss about pathogenesis of liver cirrhosis and liver failure, its manifestations and complications. So let's start. And agenda for the first part of the class is firstly to explain the mechanisms of development of maldigestion and malnutrition. We are going to discuss about appetite disorders. Briefly, we'll discuss about pathology of saliva secretion. I try to explain you disorders in digestion and the stomach, which includes hypo and hypersecretory conditions. And then we move to the most common disorders such as gastritis, stomach and duodenal ulcer. And the final part of today's GIT pathology topic is investigation of secretory dysfunction of pancreas, pathogenesis of acute pancreatitis, and mechanisms of development of pancreatic shock. When we discuss about the GIT pathology, we have to mention that gastrointestinal system, which is boundary between the external and internal environments, food is prepared for passage to the internal environment. Digestion begins in the mouth, whereas the large food particles are reduced in size, mixed with saliva and converted to the semi-fluid mass. Swallowing transfers the chewed food to the esophagus. Then food passes to the stomach, where it mixed with gastric juice. Now we know this as an chyme, which passes through the pyloric sphincter into the duodenum. Exocrine secretion of the intestinal cells and digestive juices from the pancreas and gallbladder are added to the intestinal content in the duodenum. In regulation of gastrointestinal function participate number of hormones, which contribute the regulation of the both secretion and motility of GIT. Finally, nutrients propelled and mixed by musculature of the GIT, broken down into the smaller units by digestion that absorbed through the intestinal tract mucosa, absorption into the lymph or portal blood. The absorption process took place by three processes, such as diffusion, carrier transport, or endocytosis. The main function of GIT system are supplying of the organism by nutrients, excretory function, and storage function. The regulation of GIT function happens thanks to interaction between autonomous nervous system and local factors of regulation. Autonomous nervous system represents by sympathetic and parasympathetic activity. When we discuss about sympathetic activity, it mostly inhibits secretion and motility of GIT. Vice versa, parasympathetic nervous system stimulate both of them. But together with autonomous nervous system, one of the keyest role play group of the gastrointestinal hormones, which regulates some part of gastrointestinal system and influences also both secretion and motility. Among all these hormones, we have to differentiate some group of peptide, which we have to collect into the families. And we know the gastrin family, glucagon-secretin family, and other hormones and transmitters. When we discuss about the influence into GIT function, true hormones, like as an example insulin, also works and influences GIT function. And it can stimulate secretion and motility, whereas catecholamines or atropine inhibit gastrointestinal secretion and motility. When we discuss about the influence of the GIT factors into function of the different part of the gastrointestinal tract, we have to move to the interesting video which were created in collaboration between Association of American Medical Colleges and Khan Academy. So let's see how it works and how it influences GIT function.
Other than the brain, I'd say your intestinal tract, your digestive system, is one of the smartest organs in the body. Why is that? Well, the digestive tract has its own nervous system. It's got its own brain. In fact, we call it the enteric nervous system. The enteric nervous system, because the GI tract is able to act on its own without having to send neuronal information or signals to the brain or the spinal cord to regulate its action. For example, if we're in the presence of a really awesome meal, something that's good enough for any hero in a half shell, and we consume this meal and it goes through our mouth, the esophagus, and it lands in our stomach right here, and we've got our food right there, what we initiate from this, thanks to our enteric nervous system, is called the gastrocolic reflex. The gastrocolic reflex. That involves the stomach, the gastro part of this reflex, as well as the colon. Because what happens is that the presence of food in your stomach, as signal 1, tells the colon here it's time to make way for food that's coming down. So your colon will actually, as a response, take food that's in here and push it further south. And it does so to make room for the food that we're eating. That's the reason why after you eat, you feel like going to the bathroom. It's not because the food you just ingested is about to come out. It's because food that you ate a while back has come to the end of its journey, thanks to the gastrocolic reflex. So neuronal control is one mechanism our GI tract uses to control what we do when food is present. The other component we'll focus on down here is hormonal control. Now, hormones, as you might recall, are substances that are released by tissues in our body that then go through blood vessels, like this guy right here, to go to some target organ or target tissue to cause an effect. So I'm going to talk about a couple of hormones here that regulate our GI tract when food is present. So the first hormone we're going to talk about is called gastrin. Now, gastrin is a hormone that's released when we notice that there's food in our stomach. Gastrin is released out of the stomach to go to our bloodstream and then come back out actually to the stomach to stimulate the secretion of digestive juices. So recall that when we have food in our stomach is going to cause gastrin to be released from mucosal cells. The gastrin will then go on to cause secretion of a couple of things. One, you're going to get stomach acid or hydrochloric acid to be released from parietal cells in the stomach. You're going to get pepsinogen to be released from chief cells in the stomach. And remember, this is the inactive form of pepsin that must be cleaved to become active to digest protein. The other thing that gastrin does is that it increases stomach motility. Remember that one of the functions of the stomach is to churn food that's present. It's not just to release acid and pepsinogen that's going to digest food. It also physically breaks down the food. So we result in something that's called chyme. And I'll write that right there. Chyme is what the stomach sends to the duodenum. Now, gastrin release into our bloodstream is not unopposed. It's checked when the stomach acid reaches a pH of 3. When this occurs, then we're going to have a decrease in gastrin release. So low pH decreases our gastrin release. So I'm going to say red is inhibition, green is the go-ahead or the green light. So remember, the next part of our digestive process involves delivering chyme to our small intestine. And we'll specify the first part of our small intestine. And remember, that's called the duodenum. So chyme that's delivered to our duodenum. Now this is going to cause the release of two other hormones. The first hormone I'm going to talk about is called secretin. So secretin. And I've sort of started the color scheme here. But once we have chyme delivered to our duodenum, secretin is released into the bloodstream. And it goes two places. So first it's going to go down to the pancreas that I could have drawn up here on your GI tract. It sits about right there in the duodenum, but I'm just going to write it out over here. So secretin in the pancreas is going to cause the release of bicarbonate-rich solution. So this bicarbonate-rich solution is going to involve our pancreatic enzymes, but the most important part that we want to focus on here is the bicarbonate. And why is that? Well, the whole stimulus for secretin release was the acidic chyme that was delivered to our duodenum. So of course we'd want to release a base, like bicarbonate, to neutralize that acid. The other place secretin is going to go from our bloodstream is actually right back up into the stomach. This is going to cause an inhibition of stomach motility and acid release and pepsinogen release, the kind of things we saw happen with gastrin. The other hormone that's going to be released because we have chyme in our duodenum, the acidic chyme in our duodenum, is called cholecystokinin. And as you remember, this is a hormone that's related to our gallbladder. And just like secretin, our cholecystokinin is released from our intestinal mucosa, so I can draw it coming from, say, here, into our bloodstream, and it's going to go two places as well. One, it's going to go to the pancreas to stimulate the release of our pancreatic enzymes. So release our pancreatic, I'll just write panc here, pancreatic enzymes, and this will help in our digestive process. One of the enzymes that is released from the pancreas that I'll explain in a minute, and it'll help clarify things, is lipase. Remember, lipase is used to break down lipids, right? So that's what the LIP stands for. We're breaking down lipids. The other thing cholecystokinin is going to do is go through the bloodstream and arrive at our gallbladder. It's going to go to our gallbladder. And at our gallbladder, cholecystokinin is going to cause the gallbladder to contract. So contract our gallbladder. And what do you think happens when the gallbladder contracts? What's the main function of our gallbladder? Well, if you remember, the gallbladder is holding bile that was produced in the liver. So when you squeeze the gallbladder, you're going to pump bile out of the gallbladder into the cystic duct and down and out through the common bile duct into the duodenum. And that's going to help emulsify fat. And lastly, the other thing that cholecystokinin does is that it comes back here and decreases our stomach motility. We want to slow down the release of our chyme from the stomach because we need some time to process what we already have in here. Now, is it plain old chyme that causes our cholecystokinin and our secretin to be released into the bloodstream? Or is it something more specific in the chyme? Well, let me ask you, why do you think cholecystokinin was released? If we had to point to a specific nutrient that was in the chyme that requires then our gallbladder to contract and release bile and have our pancreas release an enzyme like lipase, what kind of nutrient do you think I'm suggesting here? Or macromolecule? Well, if you said fat, you're absolutely right. It's the fat in our chyme that specifically causes cholecystokinin to be released. Okay, so what about our secretin? Well, again, this is up to you. Think about what's happening because of the secretin. The main thing here is that we're having bicarbonate be released. And so bicarbonate's a base, and we talked about how that's important for neutralizing our acidic chyme. So it's not really a macromolecule that causes secretin to be released. It's hydrochloric acid. It's the acidity of our stomach acid that's now delivered to our duodenum that causes the need for our bicarbonate-rich solution from the pancreas. So great, I think we have a good idea of how our GI hormones are helping us so far, at least in our intestinal tract. Now I know that I gave a little shout out to the pancreas here, and we separately talked about how insulin is released when we have an increase in glucose levels in our bloodstream to help us store that glucose for later use. And then the opposite occurs when we have a decrease or low levels of glucose and we cause glucagon to be released to increase the amount of glucose then in our blood. Together, these hormones work in a very beautiful manner to make sure that we have the correct hormone to respond to the right stimulus so we can get food that just arrived in our stomach processed all the way to the very end, thanks to our hormones, and as we mentioned earlier as well, thanks to our enteric nervous system.
Together with mentioned above hormones like gastrin, like cholecystokinin, like secretin, we know huge group of another hormones which also can stimulate motility or secretion. Let's tell about them. First of all, we have to discuss about stimulators of the GIT secretion, and one of the most important hormone is duocrinin. Also, enterocrinin can stimulate secretion in small intestine. For hormones which participate in stimulation of motility, we have to name motilin and villicrinin. The last one stimulates the rhythmic movement of villi in the intestine. According to its name, VIP, or vasoactive intestinal peptide, acts as a vasodilator and it also involved in bronchiolar dilation. Pancreatinine inhibits the pancreatic exocrine secretion. Substance P can stimulate smooth muscle contraction and thus gastrointestinal motility. Neuropeptide Y and neurotensin stimulate neurotransmission. So such kind difficult from one point of view, but very smart regulation helps to successful GIT function, helps to interaction between different parts of the gastrointestinal tract. And now we have to move to the definition and classification of the main idea of today's topics, concept of insufficiency of digestion. According to the main function of digestion is supply of the organism by main foodstuffs, water, salts, through oligomers disintegration and monomer absorption. Disorders of nutrition means insufficiency of digestion, and finally it results in malnutrition, which we can classify it into two types: primary, which is associated with diet abnormalities, and we have to tell about starvation, different type of it, complete or incomplete, absolute and relative, associated with social problem or associated with private choice, like in case in strong vegans. But as in medical doctors, you will be more familiar with secondary malnutrition, which is associated mostly with GIT pathology, with disorders in different parts of GIT function, and also which is associated with disorders in regulation. So secondary malnutrition, it's the situation when supply of nutrients is adequate, but malnutrition may result from nutrients malabsorption, impaired nutrient use or storage, excess nutrient loss when we see in infectious disease, or sometimes increased needs for nutrients, which could be or associated with some transient situation like breastfeeding or pregnancy, or could be caused by some severe problem like in patient with cancer. When we will discuss about etiological factors of malnutrition, we have to tell that here we see strong interaction between internal and external factors. So we have in a group external factors, which is associated with diet problem, with different infectious, disturbances of neurohumoral regulation, and strong hereditary predisposition for different kinds of disorders, like as in stomach ulcer or duodenal ulcer, non-specific ulcer colitis, or some other things. But when we discuss about etiological factor, we also have to tell about the different poisons and different habitants which can negatively influence GIT function, and it sometimes can result in severe disorders like liver cirrhosis, liver failure. Sometimes it can cause toxic hepatitis or other things. Together with division of malnutrition into the primary and secondary, we also have to differentiate disorders of GIT function according to its initial level. And we have to differentiate into disorders of appetite, the problems with passage of food through the esophagus, stomach pathology, intestine pathology, pathology of the pancreas, and some neurohumoral disorders. And let's start from the disorders of appetite. And there are two main problems which is associated with modern world, is anorexia nervosa and bulimia. Anorexia nervosa is self-induced starvation resulting in marked weight loss. Together with bulimia, both these disorders are known etiology and most commonly begin during adolescence in women. Both of these disorders have unique and puzzling symptoms, such as restricted eating or binge purge behavior, body image distortion, and specific resistance to treatment. There are often chronic and relapsing disorders, and unfortunately anorexia nervosa has the highest death rate of any psychiatric disorder. Individuals with anorexia nervosa and bulimia are consistently characterized by perfectionism, obsessive compulsiveness, and dysphoric mood. Now we have some proven knowledge about the altered brain serotonin function, which can contribute to dysregulation of appetite, mood, and impulses control in both anorexia nervosa and bulimia. Several factors may act on this disorder to cause anorexia to start in adolescence. Firstly, it could be puberty-related female gonadal steroid or age-related changes may exacerbate dysregulation of brain serotonin. And secondly, stress or some cultural and societal pressure may also contribute by increases anxious and obsessional temperament. Finally, people with anorexia nervosa enter the vicious circle, which accounts for the chronicity of this disorder because caloric restriction results in brief respite from dysphoric mood. When we discuss about the clinical manifestation, mostly it's associated with very severe decrease of body mass index and prominent endocrinopathies, which includes amenorrhea and hypothyroidism. Unfortunately, without qualified psychiatric help, this patient can die from cardiac arrhythmia or sudden death, which resulting from hypokalemia. For bulimic patient, we have some more favorable prognosis. This patient usually have near normal body mass index and normal level of gonadotropin level, but they also suffer from some electrolyte imbalance and can suffer from pulmonary aspiration of gastric contents because of specificity in behavior. Let's see the patient with anorexia nervosa. One of the problems in bulimia will be self-induced vomiting, which can be caused by higher tendency of bulimic patient to be perfect, to have good appearance. Vomiting could be associated with different sympathetic and parasympathetic responses. And you have to remember that both of this kind of patient with bulimia and with anorexia nervosa should be treated by psychiatrists, not GPs. One more problem of the GIT function could be associated with disorders in digestion in oral cavity. And it could be caused by disorders in teeth, some stomatitis or inflammatory disorders in stomach mucosa, in oral cavity mucosa, But as an causative agents for this stomatitis could be disorders in the salivary glands. And both of them we subdivided into two types. It's the hyperfunction and hypofunction. Hypersalivation usually associated with increased parasympathetic influences, which could be caused by pregnancy, toxicosis, or intake of some drugs, and it could lead to hypohydration and stomatitis. Hyposalivation, vice versa, associated with increase of different emotion, with releasing of catecholamines, pain, fever, also intake of some drugs which have sympathetic stimulating influence, and antidepressants. Disorders in salivation, both of them, hypo and hyper, can influence digestion in lower part of the GIT. As an example, decrease of salivation associated with decreased level of amylase and undigested carbohydrates in oral cavity, and it leads to disorders in stomach digestion. And vice versa, in hypersalivation, we will see swallowing of lots of food with too many saliva amount, which leads to increase of pH in the stomach, and it also leads to disorders in digestion in the stomach. So let's see that the problem with appetite or with salivary glands influences low part of GIT disorders too. The next group of disorders is pathology in esophagus. Mostly we have to tell about two types of disorder, is the achalasia of the esophagus and gastrointestinal reflux disease. And let's start from the gastrointestinal reflux disease. We have to join to the video
Gastroesophageal reflux disease, GERD. This is a regular irritation of your esophagus. That's the part of your digestive system that goes from your mouth to your stomach. The irritation you feel is from acid that has escaped your stomach. Normally, a muscle at the bottom of your esophagus tightens to keep food and stomach acids in your stomach. If you have gastroesophageal reflux disease, this muscle does not stay closed. It lets acid from your stomach leak out. The acids burn the inside of your esophagus. Certain conditions like obesity, pregnancy, a hiatal hernia, asthma, and diabetes can increase your risk for this disease. Acid in your esophagus can cause a burning pain in your chest. We call this heartburn. You may also have a sour taste in the back of your throat. You may have a dry cough, sore throat, hoarseness, and trouble swallowing. You may feel like you have a lump in the back of your throat. Many people can manage this disease with medications. These can reduce your stomach acid. They can help heal your esophagus. They can help strengthen the valve between your esophagus and your stomach. You may also benefit from changes in your lifestyle. If these options don't help you, you may benefit from surgery. Your healthcare provider can create a care plan that is right for you.
So as you understand from the video from Johns Hopkins University, and which were created for the patients, the most idea is to inform the patient that in spite of not so severe symptoms, gastroesophageal reflux disease should be treated in time. It's associated with higher risk of the tendency and development of strictura if we see progression and long-term dysphagia. And another risk is the higher tendency to malignization. The situation of high irritability of the esophageal mucosa by a strongly acidic gastric content leads to replacement of squamous epithelium of the low esophagus with columnar epithelium and possible development of the adenocarcinoma. So again, you should be very careful with this kind of patient and have to avoid the situation with long-term duration of the gastroesophageal reflux disease. And one more disorder, which is also associated with problems in digestion in the esophagus, is achalasia. Achalasia is disease which is characterized by lack of peristalsis in esophagus and is associated with relaxation failure over the lower esophageal sphincter in response to swallowing. The food gets stuck because of the lack of peristalsis. The esophagus dilates and the patient regurgitates. Finally, vomiting and weight loss is the main symptoms of the achalasia. There is an absence of ganglion cells in the mesenteric plexus of esophageal wall and a low esophageal sphincter. The pepsidergic neurons in low esophageal sphincter normally secretes VIP. We already today discussed about it with the active intestinal peptide, which relaxes the low esophageal sphincter, but these neurons are lost in achalasia. and intermittent dysphagia during meals is very typical for this kind of patient. So many patients leave the table, provoke vomiting, and are relieved. Vomiting is a classical vagal reflex phenomenon relaxing low esophageal sphincter. Unfortunately, for the treatment of the achalasia, we do not have successful results, and we unfortunately cannot perform any kind of etiological treatment because of unknown etiology. And let's move to the stomach disorders, which is associated with different problems, which usually caused by the complex of etiotropic influence, usually different aggressive influence of external factors, and also some problem with internal factors, which we know as a mucosal protection system. I'm sure that you're familiar with this kind of the factors, but I have to name them today too. So, in spite of situation with very strong acidic content in the stomach, because of releasing of hydrochloric acid and because of releasing of pepsinogen and its activation into pepsin, mucosa of the stomach has very effective protection system, which is associated with secretion of the mucus. It is also associated with bicarbonate secretion and higher blood flow to submucosal layer. All of these three factors protect gastric mucosa against the aggressive influence of the stomach juice. Together with these three factors, epithelial tight junctions also act as a protective phenomenon. But the central role in all system of protection of the stomach mucosa plays prostaglandin, particularly prostaglandin E, which can protect mucosa against the damage. And in patients without infectious, with patient without any chronic disorders, and with patient without any very aggressive influences from different poisons or some drugs, action of this protective system help to avoid erosion formation and ulcer formation. But sometimes we see some gap in action of this protection system, which finally leads to exhaustion or inadequate protection, and in clinics we will see patients with erosion, with acute gastritis, or sometimes even with peptic ulcer. When we will discuss about the etiological factors, we have to name that usually we have some interaction between external and internal factors. Patients with acute gastritis and peptic ulcer usually have some family history of GIT pathology. They also have different negative habits like smoking or alcohol intake as an example. And they also can undergo severe stress in their lifestyle. All of these factors, both external and internal, can lead to injury and can lead to changes in neurohumoral regulation, which is finally influences secretion and motility. And when we will discuss about pathology in the stomach, we have to subdivide all symptoms into different groups. One group is associated with disorders in secretion, and the same way as with salivary glands, we have to subdivide pathology in secretion and GIT into hyposecretion and hypersecretion. Also, we have to tell about pathology in motility, so increased motility or decreased motility. And sometimes we have to tell about disorders in secretion which is associated or with changes in some parts of the stomach juice, as an example, increase or decrease releasing of pepsin, or some changes which is associated with level of hydrochloric acid. But generally, when you see the patient with some GIT pathology, mostly it will be associated with two main cases: hypersecretion or hyposecretion. And together with these disorders in production in the stomach juice, we will see changes in motility too, and specific clinical manifestation which is associated with both secretion and motility problems. So let's start from the hypersecretion situation. As in reasons for the hypersecretion could be diet problems, when patient intakes lots of junk food, spicy food, intake of different drugs, like as in glucocorticosteroids, or sometimes non-steroidal anti-inflammatory drugs. It also could be associated with higher level of influence of parasympathetic nervous system, or it could be development of hyperacidic gastritis, which finally leads to increase of secretion and finally influences digestion and motility in stomach and in lower part of GIT. When we will discuss about the increase of tone of nervus vagus, it's clear because you already know the function of nervus vagus, which stimulates secretion and motility. When we discuss about the corticosteroids intake, hope you are familiar that corticosteroids influences phospholipase A2, and it finally can lead to decrease of synthesis of prostaglandin E. So here we see severe and huge influence into the protection system and depletion of this protection system, which also can finally lead to hypersecretion and damage of the stomach mucosa. So what are the sequence of reaction which is associated with hypersecretion? Usually hypersecretion leads to increase of peristalsis, and it leads to long-term closure of the pyloric sphincter, even to development of pyloric stenosis, which leads to long-term food retention in the stomach. And in the stomach we will see full digestion in the meal particles, chyme. From one point of view, this food retention can lead to gastric acid regurgitation, and patient can suffer from heartburn, and it's very common complaints from the hypersecretion patient. But from another point of view, according to the links between gastrin family and secretin family, you understand that gastric secretion increases leads to increase of secretin releasing and cholecystokinin releasing, which leads to hypersecretion, both pancreatic and bile hypersecretion. And the same situation, full food digestion, we see not only in the stomach but in intestine too. It finally inhibits peristalsis in lower part of the GIT and can lead to development of constipation among the patient. So what are the main symptoms and common symptoms which can tell you that this patient possibly suffer from hypersecretion? Is the heartburn, is the constipation, is the situation which can be characterized by pain, because you understand that hypersecretion, if it's not some short-term situation, leads usually to the damage of the stomach mucosa and can manifest with gastritis, or even sometimes can lead to development of stomach ulcer. So pain will be usually associated with intake of food, and this period of onset of pain also tell you information about the possible problem, or it will be corpus of the stomach, or it could be pyloric part of the stomach, or even sometimes it could be duodenal. So more lower localization is characterized by long period after intake of food. Compared to hypersecretion, in situation with hyposecretion, usually we see as an etiological factor development chronic atrophy of the stomach mucosa. And one more causative agent, it could be stomach cancer. Also, as an etiological factors could be some changes in neurohumoral influences and increase of tone of sympathetic nervous system, and also some deficiency of hormones, as an example. Also, one more cause of hypersecretion could be decrease of amount of the total blood volume and some hypohydration, which finally leads to decrease of secretion. If we make some scheme of the pathogenesis of hypersecretion, here also very close interaction between secretion and motility, and decreased acidity associated with decrease in peristalsis, and finally it leads to processes of bacterial fermentation of food in the stomach, and this patient usually will suffer from such complaints as in nausea, as in vomiting, and it could be foul smelling regurgitation. And strong association between stomach and lower part of GIT and situation with hypersecretion in the stomach associated with inhibition of pancreatic and bile secretion, which also lead to accumulation of undigested food particles in the duodenum and in lower part of intestine, which is clinically manifested with diarrhea. So as in a complex of hyposecretion complaints, patient will be nausea, vomiting, full smelling regurgitation, and diarrhea. Both of them, hyper and hyposecretion, clinically could manifestate as a chronic problem. And as an additional problem with hyposecretion will be hematological disorders, because you have to understand that atrophic gastritis and stomach cancer could be characterized by formation of megaloblastic anemia, and additional symptoms could be associated with this hematological problem. So my proposal is move from the pathogenetical mechanism to diseases. And one of the most common diseases in GIT and in stomach particularly is gastritis. Gastritis occurs at least two typical manifestations: acute erosive gastritis and chronic non-erosive gastritis. We have to tell that gastritis is usually focal inflammatory lesion of the mucosa. Sometimes the erosion extends into the deeper layer of the wall, beyond the lamina propria, to form acute ulcers. Acute gastritis is produced by different negative influences, like alcohol, like drugs, and we mentioned already about the glucocorticosteroids and non-steroidal anti-inflammatory drugs, or very close association of acute gastritis with Helicobacter pylori infections or some viruses. After severe stress, the gastritis may develop into a life-threatening condition with stress ulcers and hemorrhage formation. And stress condition could be different. It could be severe burns, trauma, shock, or even sepsis. When we discuss about some other etiological factors of acute gastritis, it could be also chemotherapy with higher risk of development of necrosis in the epitheliocytes, and some neurological and endocrinopathies disorders, which is also associated with higher level of glucocorticosteroids, as an example, ulcers in Cushing syndrome or Cushing disease. The gold standard method for diagnostic of the acute gastritis is endoscopy. And here in picture, you see the different diagnoses in endoscopic picture between normal atrium and atrium with acute gastritis, which is manifestates with redness and with all clinical manifestation of the acute inflammation, such as rubor or redness, such as tumor or edema, such as increase of local temperature, such as pain, and such as loss of function. So everything will associated with this acute inflammation. And acute gastritis, usually as a method of treatment, it should be etiotropic treatment. If you understand that the cause of acute gastritis is intake of non-steroidal anti-inflammatory drugs, you have to change this kind of therapy. Patients have to stop intake alcohol and smoking, and critically ill patient should be treated according to its primary situation and primary condition. Also, etiotropic treatment could be associated with symptomatical treatment, which help to support protective system. So we can use in such kind some medicines which help to increase of level of prostaglandin E synthesis, some anti-secretory medicines, or some medicine which can increase the level of bicarbonate ion in stomach mucosa. So when we discuss about the acute situation, it's more or less curable situation, and in time diagnosis could be characterized by complete recovery of the patient. Compared to this state, in chronic situation, we have some problems and we have tendency to progress of the chronic inflammation to some other more dangerous situation. According to the etiological factors, we divided gastritis into three types. Type 1, or according to another classification, type A, autoimmune gastritis. Type B, or type 2, is Helicobacter gastritis, Helicobacter associated gastritis. And type 3 is the chemical gastropathy, which is associated with non-steroidal anti-inflammatory drugs. And we have to start from the first one, is the pathogenesis of autoimmune gastritis. Usually this disorder is associated with formation of autoimmune process. Sometimes it could be only localized in the stomach autoimmune process, but it's associated with formation of autoantibody against parietal cells. And we see classical autoimmune inflammation with releasing of different pro-inflammatory cells, like lymphocytes, sometimes neutrophils, plasma cells, which migrate to the stomach and which support this autoimmune inflammation. Usually, this atrophic gastritis is characterized by involvement of the fundus or corpus of the stomach. As a compensatory mechanism, according to the decreased secretion, because autoimmune gastritis is always hyposecretive gastritis, we will see increase of gastrin level in the blood, and it's one of the markers of hyposecretive autoimmune gastritis. According to the type of autoantibody, it also could be directed against the intrinsic factor, and secretion of Castle factor could be decreased, which manifestates with B12 deficiency anemia, megaloblastic anemia. And if we are going to investigate the level of secretion and components of the stomach juice, we will see low secretion of acids and some changes in enzymatic activity, which finally leads to all this picture which we discussed before about the inadequate secretion of the pancreas, inhibition of bile secretion, undigested food, and malabsorption and malnutrition finally. So patient suffer from nausea, vomiting, diarrhea, loss of weight, and hematological disorders. When we discuss about the degree of autoimmune gastritis process and about the degree of inflammation, we have to tell that it starts from severe inflammation, and then it characterized by formation of atrophy in the stomach mucosa, and with increasing of time we see the changes of inflammation from higher grade to the low intensive, and this with increasing time we see prevalence of atrophy in the stomach mucosa. And together with this, we will see correlation between level of atrophy and intestinal metaplasia and interaction of atrophy and risk of dysplasia and malignancy. So with increasing of time, all of these three processes are increased. So increasing of atrophy, and it associated with higher risk of dysplasia and malignancy. So such kind of patient with atrophic gastritis should be again diagnosed in time, and endoscopy helps you to put correct diagnosis. As a method of treatment, we also have to start from etiotropic treatment and avoid to reason if it's possible. If not, and we see this autoimmune inflammation, and unfortunately we cannot help to this patient with etiotropic treatment, it should be pathogenetical treatment for decrease of this inflammatory process. It helps us to avoid the spread of atrophy, and it helps us to prevent of development of dysplasia and malignancy among this patient. And also, if this situation is associated with hyposecretion, we have to use substitutional therapy for support the digestion in the stomach and in lower part of the GIT. The next part of gastritis is chronic gastritis type 2, which is non-immune in origin and which is characterized by another localization compared to the previous ones where it was in corpus mostly and in fundus. Here in type 2 gastritis, it's the antral predominant localization. Also another situation with secretion. Here we will see high pus secretion and normal or sometimes increased the level of the gastrin. If we will discuss about the etiotropic and etiological influence which leads to development of chronic gastritis type 2 or type B, we have to tell about the HP infectious or Helicobacter pylori infectious, which is the chief cause of type 2 gastritis. Here in picture you will see the scientists, Australian scientists Barron and Warren, who got the Nobel Prize for discovery of Helicobacter pylori and who create this discovery which helps us now to treat the patient with Helicobacter pylori infectious and with chronic type 2 gastritis. When we discuss about the properties of Helicobacter pylori, we have to, I think, that add the information about the peptic ulcer disease because in pathogenesis of type 2 gastritis, which is associated with Helicobacter pylori, and in peptic ulcer disease, very common way of pathogenesis, very common mechanism of its development, and the same common principles of pathogenetical treatment. So I think that we have to investigate these questions together and hope that osmosis help us to do it in a more clear way. So let's see.
Septic refers to the stomach, and an ulcer is a sore or break in a membrane. Describes having one or more sores in the stomach, called gastric ulcers, or duodenum, called duodenal ulcers, which are actually more common. Normally, the inner wall of the entire gastrointestinal tract is lined with mucosa, which consists of 3 cell layers. The innermost layer is the epithelial layer, and it absorbs and secretes mucus and digestive enzymes. The middle layer is the lamina propria, and it has blood and lymph vessels. The outermost layer of the mucosa is the muscularis mucosa, and it's a layer of smooth muscle that contracts and helps with the breakdown of food. Now, in the stomach, there are 4 regions: the cardia, the fundus, the body, and the pyloric antrum. There's also a pyloric sphincter, or valve, at the end of the stomach, which closes while eating, keeping food inside for the stomach to digest. The epithelial layer in different parts of the stomach contains different proportions of gastric glands, which secrete a variety of substances. Having said that, the cardia has mostly foveolar cells that secrete mucus, which is mostly made up of water and glycoproteins. The fundus and the body have mostly parietal cells that secrete hydrochloric acid and chief cells that secrete pepsinogen, which is an enzyme that digests protein. Finally, the antrum has mostly G cells that secrete gastrin in response to food entering the stomach. These G cells are also found in the duodenum and the pancreas, which is an accessory gland of the gastrointestinal tract. Now, gastrin stimulates the parietal cells to secrete hydrochloric acid, and also stimulates the growth of glands in the epithelial layer. In addition, the duodenum has Brunner glands, which secrete mucus rich in bicarbonate ions into the lumen. With all the digestive enzymes and hydrochloric acid floating around, the stomach and duodenal mucosa would get digested if not for the mucus coating the walls and bicarbonate ions secreted by the duodenum, which neutralizes the acid. Since the stomach walls are constantly exposed to the acid, they have a thicker mucus layer when compared to the duodenum, which is only momentarily exposed to the acid. In addition, the blood flowing to the stomach and duodenum brings even more bicarbonate, which again helps neutralize the hydrochloric acid. Finally, small signaling molecules called prostaglandins get secreted in the stomach and duodenum, and they stimulate mucus and bicarbonate secretion, as well as vasodilation of the nearby blood vessels, which allows more blood to flow to the area. And this promotes new epithelial cell growth, and also inhibits acid secretion. The main cause of gastric and duodenal ulcers is infection with H. pylori bacteria, especially in low-income countries and settings. H. pylori are gram-negative bacteria that colonize the gastric mucosa and release adhesins that help them adhere to gastric foveolar cells, as well as proteases that cause damage to mucosal cells. The majority of individuals with H. pylori don't develop any problems, but sometimes it causes a patchy pattern of damage that starts in the antrum, and then spreads to the rest of the stomach and eventually into the duodenum. Over time, the damage erodes deeper and deeper into the mucosa, eventually causing ulcers. Another cause of gastric ulcers, and less so duodenal ulcers, are non-steroidal anti-inflammatory drugs, or NSAIDs, like ibuprofen. NSAIDs inhibit the enzyme cyclooxygenase, which is involved in the synthesis of inflammatory prostaglandins. Reducing the level of prostaglandins over a prolonged period of time, though, leaves the gastric mucosa susceptible to damage, and over time ulcers can start to develop. A rare cause of peptic ulcer disease is Zollinger-Ellison syndrome, which is due to a tumor called a gastrinoma. A gastrinoma is a neuroendocrine tumor that's typically located in the duodenal wall or pancreas, and secretes abnormal amounts of gastrin. Excess gastrin stimulates parietal cells to release excess hydrochloric acid, which overwhelms normal defense mechanisms and allows ulcers to develop in the first portion of the duodenum, or even in the distal duodenum or jejunum. Peptic ulcers that result from any of these mucosa-damaging mechanisms are usually small, round, punched-out holes in the mucosa. The ulcers usually have a clean base, because the hydrochloric acid secretions and the constant churning is a bit like a dishwasher, actually keeping debris out of the ulcer. Typically, beneath the base is a layer of scar tissue and blood vessels, and occasionally the ulcers can bleed if the erosion goes deep. Gastric ulcers typically form in the lesser curvature of the antrum. Duodenal ulcers, on the other hand, usually develop right after the pyloric sphincter, and there's usually Brunner gland hypertrophy, which is a consequence of the body trying to produce more mucus to protect the damaged area. Very deep ulcers can erode into underlying blood vessels and can cause bleeding, which is a problem that's extremely dangerous when there's a nearby artery. That's because hemorrhage into the gastrointestinal tract can happen, and this rapid loss of blood can ultimately lead to shock. Two well-known dangerous spots are when there's a gastric ulcer on the lesser curvature of the stomach eroding into the left gastric artery, and a duodenal ulcer on the posterior wall of the duodenum eroding into the gastroduodenal artery. Another complication is perforation, which is when an ulcer erodes all the way through the wall of the stomach or duodenum, allowing gastrointestinal contents like undigested food and gastric secretions to get into the peritoneal space, which is usually sterile. Perforation is a well-known complication of duodenal ulcers on the anterior wall of the duodenum. When they perforate, air starts to collect under the diaphragm, irritating the phrenic nerve and sending referred pain up to the shoulder. Finally, and very rarely, long-standing duodenal ulcers near the pyloric sphincter can sometimes have so much edema or scarring that they obstruct the normal passage of gastric contents into the intestines, resulting in gastric outlet obstruction. And this can quickly lead to nausea or vomiting since the food literally can't get by. The main symptom of gastric and duodenal ulcers is epigastric pain, which is an aching or burning in the upper abdomen. Other symptoms are bloating, belching, and vomiting. Classically, gastric ulcer pain increases while eating a meal due to the physical presence of the food, as well as the hydrochloric acid production stimulated by the process of eating. On the other hand, duodenal ulcer pain decreases while eating a meal. This might be why gastric ulcers are associated with weight loss, while duodenal ulcers are associated with weight gain. Peptic ulcers can be diagnosed with upper endoscopy, which is when a tube is snaked through the esophagus, into the stomach, and then the proximal duodenum in order to see the ulcer itself. Usually during the procedure, a biopsy is done to make sure that there are no signs of malignant cells and to see if there are signs of an H. pylori infection. Treatment of peptic ulcers depends on the underlying cause. If there's an H. pylori infection, it's usually cured with a combination of antibiotics and acid-lowering medications, specifically proton pump inhibitors. Substances that can worsen peptic ulcers include NSAIDs, as well as alcohol, tobacco, and caffeine, so it's best to stop using all of those as soon as possible. And in really extreme cases, surgery might be needed. Alright, as a quick recap. Peptic ulcer disease is when a defect develops in the mucous membrane of the stomach or duodenum, and this causes epigastric pain. Occasionally, they can cause complications like bleeding, perforation, and obstruction. In a lot of cases, they're caused by an H. pylori infection, or the use of NSAIDs.
And as you understand, currently we have plenty of medicines for eradication of H. pylori and for treatment of both chronic gastritis type 2 and peptic ulcer. So this patient should be treated in time. It helps to avoid lots of problems with disease, and it helps to avoid the development the complications, which, as you understand, are very dangerous. And let's move from the stomach pathology into the pathology of the pancreas. And very briefly, we'll discuss about the main prominent disorders of the pancreas. First of all, we have to tell about the inflammatory process in the pancreas, pancreatitis, which, according to the clinical duration, we have subdivided into acute and chronic. Then we also have to tell that one of the severe problem with function of the pancreas associated with the tumor formation of the pancreas, and the tumor could be associated with endocrine pancreas function and without it. When we will discuss about the clinical manifestation of the pancreatitis, it's usually associated with higher mortality rate if it's acute situation and if it's pancreatitis with destruction. Usually this inflammatory process is associated with intake of heavy alcohol and also could be associated with biliary tract disease in more than 50% of patients. As an other causes for acute pancreatitis could be presence of gallstone in pancreatic duct, reflux of bile into the pancreatic tissue, and infections of different microorganisms. It usually ascending pathway from the intestine. Negative influence have a hemorrhagic form of acute pancreatitis. As in clinical manifestation, it's specific pain, kind of irradiation of this pain into the back, and nausea and vomiting. Estimation of the WBC characterized by increase of its count, so neutrophilic leukocytosis, and increase of concentration of pancreatic amylase in the blood also tell us information about the possible acute pancreatitis. Different additional method of diagnostic like ultrasound investigation and also can help us to make correct diagnosis. And the problem with acute pancreatitis is the higher level of mortality rate associated with a higher risk factor for development of pancreatic shock. You have to understand that lots of enzymes in pancreatic tissue, and acute inflammation leads to releasing of these enzymes and formation of process of autolysis of pancreatic tissue. And lots of active trypsin, chymotrypsin, lipases, and elastases participate in breakdown and destruction of the pancreas, which first of all leads to severe pain, and this severe pain will leads to activation of sympathetic nervous system activity, and the releasing of biologically active substances finally can lead to systemic vasodilation and development of pancreatic shock. So when we discuss about the prognosis for such kind of patient, if it's destructive pancreatitis with massive releasing of proteolytical enzyme, unfortunately we have unfavorable prognosis. But as a treatment, usually conservative, so we have to treat this patient without surgical involvement because the prognosis when we treat this patient by surgical operation, unfortunately not so good. When we discuss about the chronic pancreatitis, mostly it's associated with insufficiency of exocrine function. It manifestates with hyposecretion, and clinically patient will suffer from creaturia, steatorrhea, and amyluria because of deficiency of enzymatic activity. As in mechanisms of the and principles of the treatment, it's usually again etiologic treatment, so we have to avoid formation of different gallstones, we have to avoid intake of heavy alcohol, treat patient with some infections, and also we can use substitutional therapy for support of the GIT function and for support absorption of the nutrients. And very close to the this pathology of the pancreas, and we have to move already to the second part of today's lecture topic, is the pathophysiology of liver, which is another big gland in the GIT and which is unique organ in GIT. As you know, liver is characterized by dual blood supply, which is associated with systemic circulation and with portal vein circulation. Approximately 300-500 milliliters of blood per minute enters the liver through the hepatic artery, and near 1 liter per minute enters by the way of the portal vein, which carries blood from the stomach, the small and large intestine, the pancreas, and the spleen. And as you understand, liver performs lots of function. It acts as an organ which participates in all kinds of metabolism. It's the metabolism of the all main nutrients, protein, fat, and carbohydrate. It also participates in metabolism on different hormones. It participates in deamination of amino acids to urea. It also converts fatty acids to ketones body. One of the most important functions of liver is degradation of the excess of nutrients and conversion is into the substances essential to the body. And it also participates in metabolize of different drugs and hormones, so acts as an excretory organ. But as an pancreas, excretory function, exocrine function, the same exocrine function we have in liver, and this exocrine function is associated with bile production. Bile production, it's approximately 600 to 1.2 liter of the bile daily. It contains lots of components and it's important in digestion. Formation of bile happens thanks to elimination of the components of breakdown of hemoglobin and formation of bilirubin, which is formed from biliverdin. And firstly, we will see releasing in free form, then in attached to plasma albumin, it transferred to the hepatocytes, where we will see conversion and conjugation of free bilirubin into the conjugated bilirubin, which make it soluble in bile. Conjugated bilirubin is secreted as a part of bile into the small intestine. We will see conversion it into the highly soluble stercobilinogen by intestinal flora, and partially we will see reabsorption of the urobilinogen into the portal hypertension. And most of urobilinogen is that it's absorbed and returned into the liver, could be re-excreted into the bile. 5% of urobilinogen excreted by the kidney. And one of the problem with the bile production and bile secretion is associated with lack of bile, which is finally can lead to disorders of fat metabolism, and clinically disorders in bile secretion associated with specific syndrome or complex of symptoms which we know as in jaundice. So firstly, today in liver pathology we will start from jaundice. Or icterus results from abnormal accumulation of bilirubin in blood. And if you remember, the normal content of bilirubin in blood is 0.1 to 1.2 milligram per deciliter. We have to tell about jaundice when the serum bilirubin rise above than 2 milligram per deciliter. According to the specificity, sometimes we see initial symptoms of jaundice in sclera because of a special affinity of bilirubin for elastic tissue, and then only with increasing amount of bilirubin in blood we will see discoloration of the skin. When we discuss about the classification of jaundice, have to divide it into three types. It categorized as an prehepatic or hemolytic jaundice, intrahepatic or hepatocellular jaundice, and posthepatic or cholestatic jaundice. All of them is characterized by different prognosis, different outcomes, and could be associated with different disorders. Let's start from the first one is hemolytic jaundice, which is the main cause of prehepatic jaundice, which is associated with excessive hemolysis of RBC. As an causative agents for hemolysis, we have to tell about the exogenous or inherited situation and acquired situation. As in hereditary disorders which leads to hemolysis, we have to name there are three groups of problem. It is an membranopathy like hereditary spherocytosis, enzymopathy like deficiency of G6PD, and hemoglobinopathies, kind of thalassemia or sickle cell anemia. When we discuss about the acquired hemolysis, it usually could be associated with immune or non-immune reason. And when we discuss about immune, it could be or some mistake during the blood transfusion. It also could be characterized by autoimmune destruction, autoimmune hemolytic anemia. But sometimes hemolysis associated with hypersplenism with different mechanical reason. In spite the causative agent, all hemolytic patient and all patients with hemolytic jaundice will suffer from the same clinical manifestation. It could be jaundice with different degree. Sometimes it could be mild jaundice, but sometimes it could be severe. And this jaundice is associated with increased level of total bilirubin, but this total bilirubin accompanied by unconjugated bilirubin level increase. Usually stool with the normal color, and there is no bilirubin in the urine. And usually we should not tell about the pathology of hepatocytes. So prehepatic jaundice associated with increase of load into the hepatocytes because of lots of destroyed RBC. But you also have to understand that we have a different prognosis for such kind of patient, because you also, I hope, that know about the high level of toxicity of this indirect bilirubin, unconjugated bilirubin, and its ability to transfer to the blood-brain barrier, and it could be damage of the CNS. So this patient could be treated carefully, and all the purpose should be is avoid this hemolytic crisis if we discuss about them, some situation with hereditary disorders, and decrease of load with this increased unconjugated bilirubin, some kind of disintoxication therapy which decreases level of bilirubin and prevents the CNS injury. The next part of the jaundice is hepatocellular jaundice, with directly associated with some problems with hepatocytes. It usually affects the ability of liver to remove bilirubin from blood or conjugate it. As in liver disorders, which is associated with hepatocellular jaundice, the most prominent are hepatitis, cirrhosis. But also we have to name some benign syndromes like Gilbert syndrome, like Rotor syndrome, Dubin-Johnson syndrome, and Crigler-Najjar syndrome, which is associated with hereditary disorders which affect the ability of hepatocytes or to engulf bilirubin or to conjugate it with glucuronic acid or with excrete bilirubin, conjugated bilirubin from the hepatocytes. This group of disorders usually characterized by favorable prognosis, and we know them as a benign hyperbilirubinemia. So some periods of jaundice, but then periods of recovery, then relapse, but again with more or less favorable prognosis for such kind of patient compared to different progressive disorders like liver cirrhosis or liver failure. And when we discuss about the clinical manifestation and laboratory diagnostic and different diagnostic between different kind of jaundice, here in intrahepatic jaundice we will see elevation of both conjugated and unconjugated bilirubin. In urine often we will see increase of bilirubin level, and it's dark usually, and also we will see increase of level alanine aminotransferase and aspartate aminotransferase in blood. Slightly increases alkaline phosphatase. So it's easy to make diagnosis, and it's easy to differentiate prehepatic and intrahepatic. And one more kind of jaundice which is also characterized by specificity. We know this kind of jaundice as an obstructive jaundice or cholestatic jaundice. As an etiological factors, usually gallstones, but sometimes it could be strictura of the bile duct or tumor of the pancreas. And in cholelithiasis, usually we have to tell about formation of conjugated bilirubin level, which increases, but stool usually are clay colored because of the lack of bilirubin in the bile, or even complete absence of bilirubin in the bile. And urine usually is dark. Aminotransferases could slightly be increased, and serum alkaline phosphatase markedly elevated compared to the previous ones. And when we discuss about this obstructive jaundice, have to tell, and I have to show you the pictures with cholelithiasis or gallstones as in one of the reasons of development of post-hepatic jaundice. So cholelithiasis is the prominent cause of formation of this kind of jaundice. We have to tell about some metabolic disorders which leads to development of this kind of disorder. High level of estrogens, as an example, can lead to formation of gallstones. They could be different components in the structure of the stones. Could be pigment gallstone, could be cholesterol, carbonate, phosphate, etc. We have some prevalence compared to the, as an example, peptic ulcer, where is the prevalence of male. Here, severe prevalence among female. And the risk for cholelithiasis, first of all, it's the development of jaundice, and it's also characterized by disorders of fat metabolism, and also high risk and tendency of development of acute inflammation of the gallbladder, which we know as in cholecystitis. Could be different kind of cholecystitis. Let's see how many these gallstones could be found, and high risk of development of both pancreatitis with this biliary etiology, and we told today already about it, or cholecystitis caused by formation of gallstones and obstruction. As an additional provocative factors could be accumulation of different microbial agent, and also for the risk factor of development of cholelithiasis could be changes in viscosity in bile, usually increase of viscosity, and changes in dynamics on the bile inside of the liver and also in external bile ducts. But finally, again, we also can make this different diagnosis, and currently we have to use the ultrasound investigation as in routine screening, and very easy to treat such kind of patient by endoscopic surgery, which help us to avoid severe complications such as in cholecystitis or acute pancreatitis. And much more difficult to treat the patient with acute inflammation of the liver, such as in hepatitis. You know that mostly we have to tell about the hepatitis as a viral disorder, but possibly we have some other etiological factors like intake of alcohol, and we have to tell this about the specific alcohol liver disease. Some chemicals can lead to hepatitis, autoimmune diseases, and different bacteria and another virus, not hepatitis virus. You know that we have plenty of types of hepatitis, some of them more favorable in prognosis, some of them less. Mostly the problem with acute hepatitis because of the risk of development of fulminant form of it. And when we discuss about the chronic hepatitis, the problems with usually higher tendency to formation of hepatocellular carcinoma and liver cirrhosis. When we discuss about pathophysiology of hepatitis, usually we have to tell about double influence of the causative agent into hepatocytes. First of all, it could be direct alteration caused by causative agent or virus, and also could be indirect damage or secondary alteration, which is mediated by cytotoxic cytokines and by natural killer cells and T cells, And finally, it can result in hepatic cell cirrhosis, necrosis, which can lead to different consequences. If we have some additional problem, and if we have some additional disorder or very aggressive influence of the virus into the liver, this patient can suffer from low ability to regeneration, and could be progression of this kind of the injury into the chronic form. But mostly, I think that almost the 80% among hepatitis B, maybe 40% for hepatitis C, and more than 90% for hepatitis kind of A and E, there are no complications and full and successful regeneration of liver cells. But unfortunately, when we discuss about this persistence and formation of chronic form of hepatitis, sometimes we have to tell about a higher level of activity of the process and progression. And progression could be through cirrhosis into the carcinoma. When we will discuss about the manifestation of hepatitis, it also manifestates with jaundice, and currently we already know that it will be intrahepatic jaundice, which is associated with damage of hepatocytes. And also there are different periods and different, again, prognosis for recovery. When we discuss about the complication of the hepatitis, we have to remember that development of fulminant hepatitis have a higher tendency to liver necrosis with potential development of the liver failure. And sometimes it's associated with virus, mostly again it's hepatitis B, C, and D. And sometimes it could be associated with intake of different drugs. And our routine and safe, as we've seen, paracetamol could be one of the cause of the fulminant hepatic failure development. So when you administer some medicines to the patient, you have to check the state of the liver function. You have to investigate the alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, and of course bilirubin level, to understand and to think is it possible or not to treat patient with some kind of disorders. Because when we discuss about this fulminant hepatitis, it's the poor prognosis for the patient. And poor prognosis for the chronic form, because it results usually in cirrhosis. And let's see that some percent is the viral infectious. But sometimes, unfortunately, we are enemy for ourselves because of intake of some strong alcohol, because of chronic intake of this poison, socially approved but poison, and it results usually in development of cirrhosis. So let's think about it. Let's maybe change our relationship to alcohol intake, and let's see the video about this cirrhosis overview.
When cells are injured or damaged and die off, usually that dead tissue that was previously full of living cells becomes fibrotic, meaning it becomes thickened with heaps and heaps of protein and forms scar tissue. So when your liver is constantly forced to process alcohol, like an alcoholic liver disease, or subject to a viral attack for a long time, like an HBV, or anything else that causes a long-term or chronic state of liver cell or hepatocyte destruction and inflammation, your liver can become seriously scarred and damaged to the point where it's no longer reversible, at which point it becomes fibrotic, and in the liver we call this process cirrhosis. Because it's usually irreversible, cirrhosis is often referred to as end-stage or late-stage liver damage. When liver cells are injured, they start to come together and form what are called regenerative nodules. You can think of these as colonies of living liver cells. And these are one of the classic signs of cirrhosis and are why a cirrhotic liver is more bumpy as opposed to a smooth, healthy liver. Also with cirrhotic liver tissue, you'll see that in between these clumps of cells, or nodules, is fibrotic tissue and collagen. Here's a classic histology image of cirrhotic tissue. This clump of cells in the middle is the regenerative nodule, and these blue stains surrounding it are the bands of protein from the process of fibrosis. If we zoom out a bit and look at it with the naked eye, we'll again see these nodules, which have fibrotic protein bands in between. Alright, but how do these bands of fibrotic tissue form though? Well, fibrosis is a process mediated by these special cells called stellate cells that sit between the sinusoid and hepatocyte, known as the parasinusoidal space. Here's a pretty basic layout of the basic functional unit of the liver. You've got the portal vein and the hepatic artery that combine into a sinusoid, which then goes into the central vein. And these are all lined with hepatocytes, right? Along these, though, you've also got a bile duct, and all these three constitute a portal triad. So the parasinusoidal space, which literally means around the sinusoidal space, and stellate cells are about here. And usually, in healthy tissue, these guys' main function is to store vitamin A, and are otherwise considered quiescent, or sort of dormant. When the hepatocytes are injured, though, they secrete paracrine factors that activate and sort of change the stellate cells. When activated, these stellate cells lose vitamin A, proliferate, and start secreting transforming growth factor beta 1, or TGF-beta, which then causes them to produce collagen, which is the main ingredient in extracellular matrix, fibrosis, and then scar tissue. As this fibrotic tissue builds up, it starts to compress the central veins and sinusoids. It's thought that in a healthy, normal state, these stellate cells play key roles in the natural wound healing process. But when the liver cells are constantly injured, the stellate cells are constantly activated, and so they constantly produce collagen and factors that lead to fibrosis. And this is when complications due to cirrhosis start to crop up. As those central veins and sinusoids become compressed and push on the fluid inside, their pressure starts to build up, leading to intrasinusoidal, or sometimes called portal hypertension, which is this higher pressure in the portal veins. Higher portal vein pressure means that fluid in the blood vessels is more likely to get pushed into tissues and across tissues into large open spaces, like the peritoneal cavity. That's why cirrhosis leads to excess peritoneal fluid, a condition called ascites, and can result in complications like congestive splenomegaly and hypersplenism, where the spleen becomes enlarged because all this fluid and blood can't get into the liver, and backs up into the spleen instead. In the same way, your circulatory system starts diverting blood away from the liver because of the high liver pressures, and this is known as a portosystemic shunt. And this happens because blood flow follows the path of least resistance, and basically shunts away from the portal system and towards the systemic system of circulation. Though not fully understood, these changes in portal flow ultimately trigger renal vasoconstriction, so increased resistance in the renal circulation, which decreases blood flow through the kidneys, leading to decreased filtration, and hepatorenal failure, where kidney failure follows liver failure. The fibrotic tissue, pressure buildup, and diversion of blood from the hepatic circulation essentially reduces the number of functional sinusoidal veins, and the number of functional portal triads in general. As you have less and less of these basic liver functional units, your liver becomes less and less able to do its job of detoxification, right? When the liver isn't detoxifying the blood, these toxins can get into the brain and start causing mental deficits, a condition known as hepatic encephalopathy. Although there are several neurotoxins that are thought to contribute to the development of these mental changes, the best understood factor is ammonia in the blood, which is produced mainly in the gastrointestinal tract. Usually the liver plays a huge role in removing ammonia and stopping it from going into the systemic circulation. As the liver becomes more damaged, these and other toxins get into the brain, and patients might develop asterixis, where they have tremoring or jerky hands when outstretched. And as even more toxins build up, eventually patients can progress to a coma. Also, since the liver plays a big role in metabolizing estrogen into inactive metabolites that can be removed from the blood and excreted, patients can also experience complications due to increased estrogen in the blood, like gynecomastia, spider angiomata, and palmar erythema. And since the liver usually conjugates bilirubin, there'll be increased unconjugated bilirubin in the blood from a less functional liver, and that can lead to jaundice. Another important job of the liver is producing albumin. So again, if the liver is not functioning right, you can have a decreased amount of albumin in the blood, or hypoalbuminemia. Finally, the liver helps in making clotting factors, or proteins that help coagulate your blood. So when you aren't producing these coagulation factors, you can develop issues related to your ability to coagulate blood, which you need in order to stop blood loss after an injury, right? So to recap the general symptoms of cirrhosis, early on with a small amount of scarring and fibrosis, we call it compensated cirrhosis, meaning that the liver can still do a lot of its job. In this case, somebody with cirrhosis might not have any symptoms, or they might have nonspecific symptoms like weight loss, weakness, or fatigue. Later on, though, with extensive scarring, the liver progresses to decompensated cirrhosis, and it can't function normally. At this point, a lot of the described symptoms start to develop, like jaundice and pruritus or itchy skin, ascites, hepatic encephalopathy, which can lead to confusion, and easy bruising from low coagulation factors. For diagnosis, the gold standard is a liver biopsy, which is taking a tiny sample of the liver tissue and examining it under a microscope. Common lab findings include elevated serum bilirubin, as well as elevated liver enzymes like aspartate aminotransferase, or AST, and alanine aminotransferase, or ALT, where AST is usually more elevated than ALT. Also, alkaline phosphatase, or ALP, and gamma glutamyl transpeptidase, or GGT, can also be elevated. And there might also be thrombocytopenia, or low platelet count. As to treatment, generally the scarring in cirrhosis is irreversible. So first of all, it's important to prevent continued liver damage by identifying the underlying cause and treating that. For example, stopping alcohol consumption or antiviral treatment for those with hepatitis C. With advanced cirrhosis, though, where the liver stops functioning, a liver transplant might be needed. Alright, as a quick recap, cirrhosis is when inflammation and liver damage causes the liver to become fibrotic and develop scar tissue. Causes include things like excessive alcohol consumption or prolonged viral attack, like from hepatitis B or hepatitis C virus. Over time, as the liver becomes less functional, symptoms like jaundice, ascites, easy bruising, and hepatic encephalopathy develop. Diagnosis is often done with a biopsy or through lab tests, and treatment for advanced cirrhosis is to treat the underlying cause, but sometimes a liver transplant is required.
As you understand from this perfect overview, liver cirrhosis means liver failure development, and it's usually lack of not only one or two or three liver function, but it's full of all liver functions. And it's characterized by complex of hematological disorders, endocrine disorders, skin disorders, and formation of different additional involvement of other systems into pathological process with formation of encephalopathy or formation of hepatorenal syndrome. And as you understand that this complex of the liver altered function associated with primary liver function. So it will be problem with releasing of bilirubin and jaundice development, and complex of the problem with metabolism of sex hormones and with glucocorticosteroids and with other steroid hormones. It's an ability to metabolize in proper way the drugs. It's associated with hypoglycemia, usually because of damage of carbohydrate metabolism, and problems with glycogenolysis and gluconeogenesis. It's impaired synthesis of lipoproteins and altered cholesterol level. It also elevation of different waste products like increase of ammonia level, and it problem with synthesis of plasma proteins, which is characterized by enzymatic deficiency and deficiency of albumin, and decrease of synthesis in clotting factors, which is characterized by bleeding tendency. It also problem with storage function of the liver, which leads to deficiency in fat-soluble vitamins and other vitamins, and also ion imbalance. And finally, when we discuss about the influence, it associated with in terminal stages with multi-organic insufficiency with formation, as an example, hepatorenal syndrome, which is associated with progressive azotemia, increase of serum creatinine level, and oliguria. So to make some summary for today's class, I want to tell you that pathology of GIT and particularly pathology in liver are very common among the current population, and some of these disorders could be treated easily if we diagnose this patient in time, but some of them are characterized by progressive duration, and only liver transplantation, like in case in liver cirrhosis, can help to the patient. So I think that more amount of information about hepatorenal syndrome and about the pathology of kidney we will discuss next time. And now I have to tell you thank you for your attention, and stay safe and stay at home. Goodbye.